Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Thank you for being here. I'm super happy to actually do this presentation. This is something that is really near to my heart and something that I have enjoyed during my career. Then I want to talk to you about head and neck lymphedema, what you need to know. I'll be focusing mostly on cancer-related head and neck lymphedema. Again, my name is Carolina Gutierrez. I am an assistant professor in cancer rehabilitation at the Department of Physical Medicine and Rehabilitation. I also have an adjunct appointment with the ENT department with head and neck surgery. I'm an attending physician at Tier Memorial Hermann. And for you all of you, or some of you that may not know, this is a rehabilitation hospital. Then for disclosures, I actually participated in some of the studies with Tactile. So they have a product that I'm going to be talking about, and they provided some support for those studies. Then I just want to make sure that all of you know that. The background, I already told you a little bit. This is the Texas Medical Center. This is what I'm every single day or most of the days. I completed my medical school, and then I decided to actually go into a residency in physical medicine and rehabilitation. And then after that, I subspecialized in cancer rehabilitation. Then during my job, I was able to actually work as a cancer rehabilitation, but I found a wonderful group in head and neck cancer, and this is one of the things that are very close to my heart, and I really end up working with head and neck cancer patients, and that's why I'm going to show today to you some of kind of like what have come out of all this work and how we're trying to improve patient care and cancer care. Then, as I just mentioned, I'm a cancer rehabilitation physician. Then, what is that? Some of you may know, some of you may have no idea, and that's okay. Not everybody really knows. But cancer rehabilitation is really important, and I'm going to read this to you. It's the medical care that should be integrated throughout the oncology care continuum, delivered by trained rehabilitation professionals who have it within their scope of practice to diagnose and treat patients' physical, psychological, and cognitive impairments in an effort to maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life in this medically complex population. And the translation is, my role is to help patients going throughout the journey of cancer at any time from the time of diagnosis, making sure that they can do all the things that they want to do or things that you give for granted, like walking, thinking, swallowing. And if we know that the cancer is going to, and the cancer treatment is going to bring some side effects, we want to ameliorate those and buffer those and decrease those and work on improving function as much as possible. And after treatment, help to restore function and to recovery. Going to recover as soon and as fast as possible. Then with this, now we move on to what we're here for. Let's talk about, our lecture is about lymphedema in head and neck, but let's start with the basics. Then we already know what is cancer rehabilitation. Then let's talk about the lymphatic system. Then the lymphatic system, the main function of the lymphatic system is to transport lymph, and that actually comes from Latin lympha, that means water. Then it's water transportation throughout our bodies, but it has also other functions. One of the functions is part of the immune system. And when I think about lymphatic system, I think about, like we all know about arteries, we have veins, but we always forget that there's a third system that is the lymphatic system. Then whenever lymphatic system comes to my mind, I think like, okay, it's like veins, arteries, and lymphatics. And it has different components, are lymph vessels, nodes, and lymphatic tissue. Then the way that I can visualize it, and it really helps me, is I think about highways. There's lots of different highways, and we have parking lots. Then the highways are the vessels, and the parking lots are the nodes. Then everything has to be really in an equilibrium. Then all the cars can move in one direction. They can park whenever they need to park, and then they can move out of the parking whenever they need to do that. And it drains, as we mentioned before, water, fluid, also has an effect on some of the proteins, moves some of the proteins, and part of the immune system as well. Then we have a picture here. These are all the lymphatics around our body, and then we have some of the lymph nodes as well. And the main goal is to maintain fluid homeostasis. What that means is to be able to flow and take all the fluid from some parts of the body and move it to where it has to go. And it's actually very, very important as part of the immune system. And one thing that is really important, whenever somebody has been diagnosed with cancer, cancer actually can travel through the lymphatics. And that's the way that sometimes in some types of cancers, you can actually have metastases. What we can see here on the left side, we see a vessel with an arrow going upwards. Then what that means is the flow only goes one way. Then it's not a two-way traffic, it's only a one-way traffic. And we want to make sure that the fluid goes that way all the time. And what I want to highlight from here is that 1/3 of the body lymph nodes are located in the head and neck region. And if we see here, 1/3 should be localized on the head and neck. Then this is an area that we should not be overlooking, and it's very, very important when we talk about why somebody can have head and neck lymphedema. Then we talk about what is the lymphatic system. Let's move on into what is lymphedema. The lymphedema is the dysfunction of the lymphatic system. Basically, this lymphatic system is just not working. Something is happening. The cars cannot move through the highway. There's some problems in the parking lot. What is going on? Something is happening, and then all the cars are getting stuck. Then when the lymphatic system is not working, there will be a fluid accumulation, and the way that we will present or we can see it is by swelling. And it can occur anywhere because, as we saw in the previous slide, there's lymphatics everywhere, and then there's lymph vessels everywhere. Then anywhere where we have lymphatics, lymph nodes, and lymph vessels, we can actually have lymphedema. And one of those areas is head and neck, but it could be arms, legs, pelvis, anywhere. And it's divided into two categories. One is the primary, that is mostly genetic, and the secondary. Secondary means that you had a great system, everything was in place, everything was working, but then something happened, and then that system gets damaged. Then secondary could be because of trauma, but in this case, we're going to focus mostly on cancer. Cancer itself can actually damage the lymphatic system. Radiation, that is part of the treatment that we use for head and neck cancer in this case. And then when the lymph nodes are removed, that actually can actually cause damage of the lymphatic system and can end up in lymphedema. And then we have other causes. And in this case, we'll call it cancer-related lymphedema because there's cancer, and then we know that because of the cancer and the cancer treatment, we're going to develop a malfunction of the lymphatic system. Then something is happening. There is a disruption of these lymphatic vessels, and then this fluid is not going where it's supposed to go, and it's getting accumulated, and then we're seeing a lot of swelling. Then most often, and I want to stop here for a little bit, most often has been associated with breast cancer treatment of axillary lymph node dissection and radiation treatment. That means that in breast cancer patients, whenever they undergo large surgeries where they remove all the lymph nodes, and then after that they have radiation, those patients are actually at a higher risk to develop lymphedema. That translates, the more you do to the lymph nodes, the more you can damage them, and the higher risk to develop lymphedema. But there's another point that is really important here. When we talk about breast cancer, usually most of the literature has been focused on breast cancer. Then it seems like breast cancer-related lymphedema is the most common one. But I think that this is based on how much breast cancer-related lymphedema has been studied, and that is really easy to diagnose. If you see a picture here on the left, you can actually tell a difference in between the right and the left arm. One looks very skinny and the other one looks very puffy and large, has a larger volume. Even if you look at the fingers, they look completely different. Then it's easier to be able to diagnose for most of the cases. Breast cancer-related lymphedema. Lymphedema is a chronic condition. That means once you have it, you have it. You will not go away. You have it, but you can treat it and you can improve it, and then you can make it better. And then you may have certain times of your life that you have your lymphedema completely managed. You may have flare-ups, but it's treatable. This is very important. It's treatable. We should be treating lymphedema. And if left untreated, can actually progress to fibrosis. Fibrosis is thickening of the tissue when the tissue becomes kind of like very hard and then scarring tissue, and also increases the risk for infections. Then when we talk about head and neck cancer related lymphedema, we have a picture on the right that is showing us the different parts where the cancer can actually occur. And it could be anything from the tongue, the back of the throat. There's many different places, and then we can actually localize, and sometimes cannot localize where the cancer is. And based on that, and based on the size, and the cancer will have different treatments and different approaches for treatment, from surgery, radiation, chemotherapy. Then we know that about 4% of all cancers in the United States are head and neck lymphedema. Our population is pretty large, then that's a big, big population. There is an estimate that 16,630 people will develop head and neck lymphedema, head and neck cancer this year. Most of the patients are male, but there's also a female population, but it's predominantly more common on males. And then I'm going to move on to this. Part of head and neck cancer can actually be related to HPV. HPV is a virus that has been involved in different cancers. We have here vulva, cervix, anus, oropharynx, and vagina. But what I really wanted to focus on is the blue, like light blue line that is oropharynx. These are the cases that have actually increased in the head and neck population, and we're seeing more and more. But I wanted to see this. They start occurring like around 20 years old, but we see that they actually increase the prevalence. That means that there's more cases whenever the patients are around 40 years old, all the way to 70. So that means that you have a diagnosis, undergo a treatment, and then you have the side effects of those treatments. And one of the side effects is lymphedema. Then these patients may be having the side effects as soon as age 30 or 40. Then it's even more important to address the secondary effects, including lymphedema, of the head and neck treatment. Okay. We have a picture here, and this is very common. This is usually what we see, this gentleman on the left. We see this kind of like puffiness, or what we can call double chin. Then in the past, some people used to say, well, this is just cosmetic, this is not important, it's actually swelling from surgery, swelling from radiation. But most of the time, the skin is already healed from radiation, and it's healed from surgery, and you still see that puffiness. Then what is going on? Again, they will say, well, this is just cosmetic. You just see a little puffiness here, and I'm going to show you why it's not. Then the patients will come to the clinic and they actually describe different symptoms. Most of them, they say, I just feel kind of like tight. I cannot tell exactly what it is. It's not really pain, but it's just tight. And it varies during the day. Sometimes when I wake up in the morning, I feel really tight, and throughout the day, make it better. They can say also, well, when I look at the mirror and I ask them, like, do you see any difference on your neck or your face? And whenever they look at the mirror, they may see that one side is puffier than the other one, and they just look very different. And let me tell you, sometimes it's hard to tell because some of these patients may have large surgeries and they may have a lot of scars and different procedures that have been done. But it's still, they can tell that one side is different from the other one. They just feel like they have some swelling. They have some limitation on range of motion. That means movement of the neck, or they feel pretty stiff. And there's many reasons for that, but definitely lymphedema contributes to that. They may have some changes in the skin. They may feel like the skin is very firm or hard, or they have kind of hard pockets or hard skin. Some of the patients may present with changes in voice. They have more hoarseness, difficulty swallowing, and I'm going to talk more about this, and also shortness of breath. Okay, sorry. Then, as I mentioned, it seems like it's a cosmetic problem, right? You have a little bit of swelling outside, and well, yeah, patients are reporting some symptoms, but anyways, looks very cosmetic. Then what we did is we actually look at the CT scans, and I'm going to walk you through these. We look at CT scans of patients before and after radiation treatment. And then if you see your image on the left, there's a black area. This is the area where actually the food goes down when you're swallowing. And then you see all the gray areas. Those are soft tissues and muscle that are inside your swallowing area, your swallowing pipe, if you can call it that way. Then after the patient received radiation, you can see the image on the right. You see that that black area where the arrow is really decreased. It's like almost non-existing. And then the most impressive part is if you look at the gray is the soft tissue and muscles, they look swollen. And this is what is happening, it's really swollen. Then this lymphedema is not just accumulating outside, it's accumulating inside. Then we know that we have what we call external lymphedema and internal lymphedema. That means lymphedema outside, like the one that you can see on the neck and face, and inside the throat and the mouth. Then in this study, they actually look at all the head and neck cancer patients. They look at all of them, and they found that 75% of those patients have lymphedema. Almost 10% of them had external lymphedema. Around 40% had internal lymphedema, and about 50% of them, they have both external and internal. And then they just look at the patients, only the patients that had lymphedema. And what they found is about 50% of the patients had external lymphedema. 68% had internal. And what they did is they scoped them, they put a camera and they look inside the throat and they saw the swelling and they say, yeah, this is lymphedema. And then both internal and external was about 38%. But I think that is really important to notice from this, if you look at the right side, there's a higher percent of internal lymphedema compared to external. Then we know for sure that there's things that are happening after treatment that we may not be able to see just when we look at the patient. Then at least for me, for my practice, the more the patient has done, I absolutely just almost assume that the patient has internal and external lymphedema because I already know that if somebody had large surgery and multiple procedures and radiation, this patient most likely will have lymphedema. And I prefer to be more aggressive on the treatment to treat it. And I'm going to talk a little bit more about that than just leave it alone and don't do anything when it's something that is treatable. Then what happened with this lymphedema, with this swelling outside, what we call external, and the inside, internal? Then we have seen that actually that can change the quality of life of the patients, can actually increase the number or how bad the symptoms related to cancer and cancer treatment are, and also changes in function. Then they found that these patients have body image issues. Then it may be easier to say that it's a cosmetic problem, but when it's you and you look different and your body is not what it used to be, and then you look at yourself at the mirror and you don't like the way that you see yourself, this is very important, and this is part of body image, how you perceive yourself. Then it really has a big impact in quality of life. Some patients may decide not to socialize anymore because they just feel like they're not looking the way that they expected or they should look. Then we also have, depending on the severity of the lymphedema, the more lymphedema, the patients will start complaining that they have problems moving the neck. Whenever the patients have external, internal lymphedema, they were reporting that they were having difficulty hearing. And overall, the quality of life was decreased. They felt that the quality of life wasn't great. And based on the severity of the external lymphedema, what they found is these patients actually self-reported, they reported themselves more difficulty swallowing, and also they related more problems with nutrition, like weight loss, for example. And for the internal lymphedema, the patients reported more changes in both. So why is it so difficult to diagnose head and neck cancer related lymphedema? It's very hard. Then if you remember the picture that I showed with the woman with the difference in between the two arms, then these patients, you can actually measure the arms even before surgery. And also you can compare one extremity to the other one if both have not been affected. You can measure one arm and then compare those measurements to the other one. And then you can say, yeah, definitely there's a change here. One is larger than the other one, then we know that something is going on. But head and neck is pretty challenging, and it's challenging for multiple reasons. The patient cannot be their own control. What that means is, for example, if we think about like, okay, let's take a picture before treatment and let's take a picture after treatment, and then we can compare. Well, these patients usually lose about 20 pounds or even more. Then it's really hard to compare. How about if somebody had a large surgery and they had to have a flap, they have to have a big reconstruction in their mouth? Then it's really hard to compare if this is just related to the weight that they lost or the fibrosis after radiation or the big surgery that they have, or it's very difficult to compare. And then we had this fibrosis that actually comes with radiation. Then the patient itself cannot be their own control. Then it's really hard to diagnose it. Sometimes once you start diagnosing it, you don't miss it anymore. It's there all the time and you can really see it. But it takes some time to really realize that this is a big problem and it's very prevalent. And sometimes it's hard. I actually touch everybody's neck and just feel how it feels the tissue, and if it's hard or if I feel any puffiness, the same for the mouth and the lower part of the face. Then we know that it's a chronic condition. We already know that we can diagnose it. It's challenging, but we can do it. And in my mind, the easiest way to think is the more the patient have done in terms of treatment, the higher the risk. Then if somebody had surgery, they removed the lymph nodes and they did the radiation, I almost assume even before I see this patient, that this patient is going to have lymphedema. Then we know that it's treatable. How can we treat it? There's multiple steps, and then you will see that this is very similar to other lymphedema, other parts of the body that you can treat with lymphedema. But the first and most important, well, not most important, I think that all of them are extremely important, is education and training. Then the patient needs to understand what is lymphedema, why it's important to treat it, learn about the treatment, know how can things change their lymphedema and what to expect. And that's really, really important. And there's also another piece of skin care, learning how to take care of their skins. And in this case, they also may have some changes after radiation, and some parts of the skin may be still healing. Then we try to be very conservative on those and make sure that the skin is really healed and closed before we start treatment for most of the patients. Manual lymphatic drainage, that maybe some of you or most of you will be familiar, is, I'll say it is very simple, but it's like a light massage that helps to mobilize all that fluid that is getting stuck and moving that fluid to another place and getting out of the way to decrease the swelling. And then exercise. Exercise, I don't know if you remember when I show you that it's actually the flow goes only one way, then the cars only go one way. Then when we exercise, and this applies actually for the venous system and for the lymphatic system, our muscles contract. Then actually that can help as a pump and help to pump up all that fluid. And then we also have compression where the areas of swelling could be compressed with bandaging, garments, taping. Oh my goodness, I don't know. The therapies are great, and they become the ones that work with us, part of our team. They come with different ideas and really try to target those areas of swelling. And then we have the compression pneumatic devices. We have a picture here on the right. Some people could consider this more like a home treatment. I think that is part of the treatment, but also depends on patient resources. And let me explain you why. And this is just based on my experience. I may have some patients that actually have access to therapy, and I always would prefer to have the whole treatment. But some of the patients may be somewhere where they have no transportation, they are by themselves, and they have no access to absolutely anything. There's no therapies around. They actually may drive to Houston for 4 to 6 hours to get to a medical appointment. Then in this case, I think that also we can use whatever we have. Even if we have the compression pneumatic device and we don't have any other therapy, I take whatever we can do. If anything can help this patient, we'll take it. But these are all the parts of the treatment, and they are all very important. And I'm going to be talking a little bit more about the compression device. And as I mentioned before, I was involved in some of the studies. Then I want to tell you exactly what we did. Then this is one of the studies where we actually, it was head and neck cancer-related lymphedema. It's called a treatment response to single and multiple sessions for advanced pneumatic compression therapy. Then if you see here, the picture on the right is like the one that you just saw, where we did, we actually had 10 participants, 10 patients that had cancer-related lymphedema in the head and neck area. And then we did some imaging, and I'm going to show you some pictures that is called near-infrared fluorescence lymphatic imaging. What is that? That's pretty much what they used to use for night light in the military, like at night, and they can put these goggles and they're able to see if somebody's moving. Then it's a fluorescent dye, actually will not even stay on your body. And what we do is small injections subcutaneously. What that means is underneath the skin. And then we actually are able to image. There's no radiation involved. There's only a dark room and a camera. And then we can see what is happening to the lymphatics. This is, to me, one of the greatest things that I have seen, because I can really see what's happening with the lymphatics versus trying to imagine what is happening. And we can see it in real time. We can put the camera and we can actually play a video, record it, and then later play a video and see what exactly happened. Then we took these patients, we injected the dye, we did imaging, and then we asked them to put on the garment and do one treatment. Then they turn on the treatment. It's a software that actually does some compression. And then after that, we image them again. And then the patients will take the garment home or the pump home. They will use it for 2 weeks. They will come back and we'll re-image again. We'll do the same thing again with the camera just to see what is happening with the lymphatics. And then we did some measurements of the face. This has been something that has been proposed, that you can actually do several measurements of the face. I think that is still quite challenging. We did it, but it depends. If you move a little bit more to the right, to the left, superior, inferior, it may change. But we did it. Then if you can see here, your picture on the left is showing you some of the superficial lymphatics and lymph nodes. And if we see on the right, we see this green image, and you see 2 black tapes. Those are tapes. Those are the sites of the injection. And we put a tape on top because the dye is fluorescent. Then if we didn't cover it, it will be just so fluorescent that we will not be able to see clearly the rest of the dye. Where is it going? It will be really bright, really extremely bright. Then we cover these places, and you can see here, you can see, I don't know if you can see my pointer, but what you can see is if you follow from the ear, it seems like the lymph is actually going this way to the front, and then it's also flowing down. You can actually appreciate this. This is actually pretty good. It's healthy. Everything is moving. We have the lymphatic moving, the lymph moving. And then we have here, this is one example of the patients that were enrolled in the study. Then we have a picture here on the left upper corner. This is the patient, had some swelling on the neck and in the face. We did the injections, and then we did image. And if you see here on the right, we just see just 2 little spots, like very bright green spots. What that means is that the lymph wasn't flowing, wasn't going anywhere. That means that the parking lot was closed, and then nobody was going into the highway. Everybody was getting stuck there. We call that dermal backflow. That's the way that we used to describe it, and this is based in other studies that have been done with some of our colleagues that are absolutely amazing in our imaging side. Then we could see this. Then later, the patient received a treatment with a compression pneumatic pump, and then you can see the image on the bottom. You can see the same gentleman, and then we did image, and then you start seeing like all this green kind of like moving through the neck, and there's some coming down, and then it seems like it really wants to cross midline and it wants to come down. Then what we saw is, oh my goodness, really, all this lymph is moving and getting from one place and going to the other one. And that was absolutely fantastic. Then we find that after a single pneumatic, that means the first day when they came, we used the pneumatic pump compression treatment, and then image again, took a picture or a video again. We actually saw that the lymphatics were moving better, then enhanced lymphatic uptake and external lymphatic drainage in all the subjects. We saw what I just showed you, that the lymphatic was really moving. Then that was great. That was the first thing that we saw. Then after 2 weeks of daily treatment, we saw the dermal backflow, that's kind of like the getting stuck that I described, disappear or reduce in 6 out of 8 subjects that actually presented with backflow. Then there was an improvement, if not better than improvement. And then for the measurements of the face, our results were mixed. But we also had some self-reported where we asked the patients how they were feeling, and they reported to feel better, and they reported to have improvements in quality of life. Then this is another study looking at patients. There's longitudinal effects of a novel advanced pneumatic compression device on patients' reported outcome in the management of cancer-related head and neck lymphedema. Then let me explain to you a little bit. Then what we did is we took 205 patients. They were head and neck cancer survivors, and they were using the pump at home, anywhere from 25 days to 288 days. Most of the patients were using the pump for around 90 days, pretty much 3 months. And then they actually self-reported the symptoms. Then they did a self-report pre-treatment, before starting treatment, and then after completing the treatment, post-treatment. And what we found is that actually the patients reported that they actually improved the ability to control lymphedema throughout home treatment. This is great. They improved the ability to perform daily activities. At least as a rehab physician, for me, this is very important. If I get my patients moving more and more independent and doing more things at home, being able to do activities easily, faster, this is a super gain. And also they feel that they had a decrease in the neck pain and discomfort, actually improved. They also find that there was less difficulty swallowing and then less difficulty breathing. Then all of these will tell us that really there is a benefit, number one, to make sure that we're diagnosing lymphedema, and number two, to treat lymphedema, because we can improve it and we can see so many changes. I said before that we're very aggressive treating lymphedema. Then one of the main problems for the head and neck cancer population is the difficulty swallowing. And we have seen that in many of our patients, if not maybe most of them. And what we have seen is, if we think about the image that had the swelling, we really want to try to decrease the swelling and treat the swelling at the same time. Then we actually do both therapies in combination. Then there's a lymphedema therapy seeing the patient and a swallow therapy, because we feel that we need to exercise the muscles and we need to improve the swallowing function. But at the same time, the swelling has to be reduced or decreased to have the best effects with the swallowing therapy. Then we do this for most of our patients, and our patients have improved significantly. And I can tell you that in the time that I'm having with this group, I can see the difference and how the patients are recovering faster and they're swallowing better and they're doing clinically better, and how we're improving cancer care. Then as a conclusion, head and neck lymphedema is very prevalent. It's prevalent in the head and neck population. One thing that I think that is important to mention, if you're going to refer a patient to be evaluated, you can always overdo it versus underdo it. I don't think there is anything wrong in sending somebody to get evaluated for head and neck lymphedema versus not doing it. If they get evaluated, they don't have anything, they may receive some medication, and the patient will be aware. If they develop any sign of symptoms, they can always come back and be evaluated again. Lymphedema really interferes with the function and quality of life. Lymphedema should be treated because it's a chronic condition that is treatable. Then you should be treating the lymphedema. And treatment for head and neck cancer-related lymphedema have a positive impact on function and quality of life. Then these patients may feel better, may swallow better, they have less pain, they participate in activities more, then it's worth to do it. And then the imaging with the near-infrared technology is an important tool for visualization of the lymphatic system. And this is what we actually had, and I show you some of the pictures. Then the tall building that you see on the left, this is where our clinic is located. And then we have a larger hospital where all the surgeries are done. You can see that on the right. And I want to share also a picture. This is our team. It's a really large team, and we all work together. We have the head and neck surgeons. We have pathologists. We have radiologists that are dedicated for head and neck, pathologists. We have a nurse navigator, and we also have our rehab team. There's a speech pathologist, a speech and language pathologist. We have a dietitian, and really everybody works together, and we try to improve patients' quality of life and cancer care. Thank you so much. Then this is the end of my presentation. I'm actually going to go to the Q and answer section in the chat and see if there's any questions. Great question. If metastasis moves through the lymphatic system, doesn't manual lymph drainage increase risk for mets? This is a great area, and I think that we're having back and forth. Yes. Even like when you take a biopsy, sometimes you can take some of those cancer cells. There's a risk. But keep in mind that most of these patients are being treated. Then whenever they're being treated or whenever they underwent radiation, you assume they have been already radiated, and then the cancer cells are not there, or we hope for that. And then what they do is they follow the patients through scans, and then they actually put the camera again inside, and they look and make sure that everything looks healthy. Then after the patients have received treatment, I send the patients for lymphedema. Different stories towards the end of life. Towards the end of life, when the patients have lots of metastases and they have lots of disease. Then at that point, we already know that they have a lot of disease and they may have limited treatment options. Then I may do it just for quality of life and be very clear with the patient and tell them this is the risk, this is the benefit. But if your quality of life can improve, if you can breathe better, if you can swallow better, and this is important for you, even though we know that it may be a risk, we really don't know. But we assume that it's a risk, then the patient can make the decision. But for most of the patients, they will be evaluated for lymphedema after surgery, radiation, chemo. Then you already assume that those patients are treated. Let me see. Okay, do private insurances cover this pump, and how much covering there is for the pump? Then I usually leave that to the company, but I can tell you that in general, we haven't had problems. I know that some insurances may cover the pump. This is the only pump that has been approved for head and neck lymphedema. Then there's no other one. I mean, the company, in my experience, has been great and have been working with all the patients. And if a patient needs the pump, they try to do as much as they can to see if the patient will qualify, and if not, to provide any kind of assistance to really help those patients to have access to the pump. Okay. What kind of workup do you recommend prior to treatment? If there's a mandatory ENT referral, imaging versus endoscopy, then we have been going back and forth with this. Like, okay, for sure, if they're scoping the patient, they're doing endoscopy just to see how everything looks, and they see swelling, that's a must. But as I told you, we started with like, oh, how can we classify these patients? At this point, we pretty much prefer to assume that most of the patients that underwent lymph node dissection and radiation, they do have lymphedema. Then we do a referral. Is it an automatic mandatory? No, it's not. But in our group, it's like so much in our minds that if the head and neck surgeon will not do it, then I'll go into a room and I'll do it. And if not, we also have a speech and language pathology that will come into a room. Then any of us will ring the bell. Most of the time, the three of us will say, yeah, this patient needs some referral to head and neck lymphedema treatment. But it's not something that is automatic, but it's pretty much ingrained. It's like one of those steps that we cover, like look at the scans and make sure the patient does not have lymphedema. Okay, they were asking me if the patient require a prescription for the infrared dye. This is only for studies. This is nothing that we're using for clinical care. It's not approved. We only use this kind of imaging, the near infrared. We only use it for studies. then it would be pretty cool if in the future we can see, maybe treat a patient and then image the patient, and that will give us better idea, and maybe we can do more targeted treatment for each patient. Maybe we can see, hey, we're doing the non-lymphatic drainage this way, and we may do it the other way, and then we can see in real time if that's affecting the flow more or not. For how long the compression garment is recommended, then that will depend, and I usually leave that to the lymphedema therapist. They may do different trials, they may do several hours on and then off, but we have to keep in mind that is the head and neck area. Then a patient cannot wear something 24. It's not as easy as telling them wear a sleeve where they can wear the sleeve in their hands and the arm all day long. Then we have to work with that and see what can benefit the patient, but also something that is doable and achievable. And for the pump, is also is recommended to be used once a day. Ooh, good question. If most of the facilities offer this, I would say that this is one of the barriers that we have. If the patients are located in our area and they're part of the system, we do have a network where our therapists in each therapy place, they have, or at least as much as we can, they have some training on head and neck lymphedema, then we have access. But I can tell you that some rural areas, they have no access to any therapy for head and neck. We always try to partner with anybody. We had a lot of patients that come from certain areas that are outside Houston, we already know. Then we actually partner with those therapies, and our speech pathologist usually communicates with them just to make sure that they really understand, and it's a win-win. Our patients get better treatment, we also help them, and they know more about head and neck, and they are more aggressive about how they can treat head and neck lymphedema safely, and also the swallowing part. I'm going through all the questions. Okay, then there was one question about if we recommend to treat internal lymphedema. Then what we have seen, and so far with the information that we have, I assume that whenever we treat outside, the inside, the internal lymphedema will get better. And why I assume that? I assume that from the imaging that we did, where we saw that the flow of the deep lymphatics was improving. Then I may think that whenever we're treating outside and inside, it's actually getting better, the internal lymphedema. And in general life, we see it too. Whenever they come back to the office and they get scoped, we see like, oh, swelling is better and the patient is swallowing better. If there is a way to differentiate internal and external lymphedema. And I have been kind of like going back and forth on this point, like how important it is to really differentiate. And what I think is pretty much the treatment at this point is the same. Then we treat the same one or the other one. Then sometimes I can say, yes, like this patient was scoped and we saw the swelling, we did a CT scan and we can see it. Then we definitely will say internal lymphedema. But for most of the time, even if it's external or internal, the treatment will be the same. Then I don't really spend much time trying to differentiate one versus the other one. I'll just treat the patient. This may change. We need more research and we need to really, really understand head and neck lymphedema better. Then we may actually end up with different protocols in the future. But as it is, this is what we do. And again, we know that whenever we use the compression, the pneumatic pump, that this lymphedema was getting better into the deeper lymphatic tissue. Then we know and we have seen it that it really worked, and the way that the patients reported too. If we have any pre-rehabilitation program, absolutely. Then this is a very special program and I'm part of it and I'm super grateful to be there. I'm actually in the clinic. Then as I mentioned before, I'm a cancer rehabilitation physician. Then the patients that get diagnosed, they are seen by the hair and neck surgeon, and whenever he comes out of the room, he's like, Dr. Gutierrez, please. Then I go into a room and we start what is pre-rehabilitation. Then at that point, I'll do a complete assessment, not just for lymphedema. I'll talk a little bit about lymphedema because it's really important that our patients are aware, but then I'll take care of everything else. Everything else means range of motion, how much are they moving the neck, the shoulders, if they're swallowing, if they have any symptoms associated, if they're having any fatigue, if they have weight loss, if they're exercising, if they're smoking, if they're drinking. Then it's a big, big list, and we start from there. And then, yes, our speech therapists will actually come into the room and talk to the patients about how they can start doing the swallowing exercises and for rehabilitation and how important it is. And then our patients will get referred. Some of the patients have more access, some of the patients less. But yeah, all of our patients get referred to do swallowing exercises, and we do more education. And then whenever they come back from therapy, therapy meaning radiation, surgery, and so on, we'll reevaluate again and see how is everything, if they're doing worse, better, if they have different needs, what can we do, how can we help them? Yeah, they say, I'm a physiotherapist that I have been working with lymphedema. For the head and neck cancer, I have had much success with stretching scar tissue and muscles along with CDT. Yes, and that's one of the things that I mentioned, the decrease of range of motion. There is a part that is caused by lymphedema, but there's also other causes because the radiation really produces fibrosis of the whole tissue. Then we have changes in the muscle, fascia, skin. We have the lymphedema. Then we have to keep in mind most of them and treat it in conjunction. Then yeah, there's a lot of tissue release, and that's part of the treatment. I'm going to read more questions. Okay, what is the best treatment for internal lymphedema? I wish I can tell you which one is best. I'll do the same treatment that we do for external or internal lymphedema, because when you treat the external, you're really treating the internal as well. Then until we have more evidence and we have different things, then I will just think that whenever you're treating the outside, the external lymphedema, you're treating the internal lymphedema as well. And that's manual lymphatic drainage, education, pump, compression devices. Okay. Is lymphedema therapy, manual therapy, compression devices contraindicated with someone who is having trouble with healing at the surgery site or has an infection? Well, yeah, infection, until the infection is not treated like any other place, we don't want to start any treatment for that lymphedema. Then whenever the patients have an active infection, we'll stop. For the wound, for most of the time, we want to make sure the skin is healed. Then yeah, if they have like an opening part of the wound at the surgical side, or the skin is still kind of like what we call raw after radiation, they still have these acute post-radiation changes, then we'll wait until they heal. There is only one caveat to it. Once in a while, we may have somebody that has a wound that is not really closing, but they have so much swelling, then we may do a trial and we may go around and say, well, let's try to actually treat the lymphedema and see if that helps with the closure of the wound. But for the most cases, we say, yeah, the skin has to be healed and there's no infection before we can treat the patient. Does the compression bandaging can assist with internal lymphedema as well as external? Yes. And I don't know that for sure. I wish we can actually visualize it, but my guess, based on so far what we know, is yes. Then do whatever you have to do, the bandaging, the compression, everything else. How often do the patients utilize the pump? Yeah, once a day. And that's the recommendation so far, is once a day. Some of the patients may use it more than once a day, may use it 2 times a day, but the recommendation is once a day. Some of my patients actually love it and they use it twice a day. They use it in the morning and in the afternoon and they feel better. But the recommendation is once a day. If one will be more beneficial than the other one, I don't know. I wish we have a study, but some people have no time and they only do it once. Some people do it twice and they tell me, oh my goodness, I just feel such a great difference that I like using the pump twice a day. Then I really leave it up to them. If it's not causing any problems, if the skin is healed, and if they have the time and they want to do it and they feel better, yeah, go for it. Okay, what is the name of the company? Tactile. And I think that was in one of the first slides. That's why I had to disclose that I actually participated in their studies. Tactile Medical. Then again, how a session for internal and external lymphedema will look like. I think that is the same. Things that we may add sometimes, and that's more based on fibrosis. There's a lot of manipulation. Some of our speech pathologists may do some mobilization of the tissue, but it will be the same treatment. Okay, I think that we have a couple more minutes for more questions. One thing that I don't know if I did emphasis enough, but I actually tell all the patients to exercise. That's part of the guidelines for survivorship. That's one of the things that will prevent any cardiovascular events and actually can help with the lymphedema. Then most of the studies have been done in breast cancer, I told the patients they have to move, they have to exercise. And that's part of the treatment and part of the survivorship recommendations. Let me go through more questions. At what time after treatment, after surgery or radiation, do you advise MLD or a pump after treatment? If we have any concerns or remaining cancer, most of the time, whenever the patients undergo all those treatments, is because there's an intent to cure the patient, most of the time. Sometimes there's a palliative effect where they just want to decrease the tumor burden. But for most of the time, it's a curative intent. Then, yeah, after radiation, the skin is healed, yeah. If some of the oncologists have concerns, at least in my group, no. I heard from some of my colleagues that some of the oncologists may be hesitant and they just want to repeat scans before they can actually start the treatment. And yeah, we really don't know for sure. But we have seen so many good effects of treating early and being more aggressive treating lymphedema, then we just go ahead and do it. And after the patient's completed treatment, there's no reason to think that they have active cancer unless we have a specific case. And I think that maybe that's why we haven't implemented something mandatory for everybody. Yeah, the patients get seen in the clinic and then we refer them. And we see so many benefits of the lymphedema treatment that we just, when the skin is healed and the treatment is completed and finished, we send the patients for lymphedema. And again, as I mentioned before, their case will be more palliative, but I think that that's also something that we should consider. If there's already metastases, if there's no more options for treatment, we may try. We tried in a couple of patients. Some of them actually, the lymphedema, I think that maybe it was one that the lymphedema got worse. Maybe it's only very few patients. But for most of the patients, if they feel more comfortable, if they feel less pain, if they feel better quality of life, I will just go ahead and do it. Again, having an open conversation and making sure that the patient understands the pros and the cons and what is involved in the treatment. Let me go through more questions. I think that we have maybe one or two more questions. Oh yeah, they have a comment here. I find that my patients will receive radiation treatment. It seems to help to get them start gentle range of motion exercises to facilitate receiving radiation more easily. Absolutely, that's part of the pre-rehab. We want to make sure that they move the neck, they move the shoulders, they move themselves, they exercise, and that's part of the education that they receive whenever they do. We have an evaluation at the beginning, for sure. Then we talked about that and how important is that. The same for breast. For breast cancer, you really have to start mobilizing your shoulders. And then most of what we want to do is prevent. We really want to mobilize as much as possible and prevent. When the patients start having pain, they really start getting into this posture, and then they have radiation, and then they really decrease the movement. And we want to keep them moving and doing range of motion. Okay, I think that I went through as many questions as I could. Let me see if anything else. Well, thank you so much. And I hope you learned something. I hope I was able to share some good information. Thank you again. Thank you so much for the opportunity for being here today. Have a wonderful day. Bye.